keynote speaker, who is Dr. Rupa Chilvers. She is a social scientist who has spent time working with clinicians, technologists, academics, behaviorists, organizational development leads, project managers, and many more people in health and social care across the UK and internationally. The main focus of her work has been in translating research findings into practice to make a new impact in the services and care that is provided. She has been focused on digital health, workforce development, and the role of immersive technologies, the role that they can play to increase understanding and connections between people. Dr. Chilvers, I've been Googling you a bit, and I've learned that you are currently working in digital, including AI and cyber programs, with a focus on workforce in health and care. According to certain sources, basically LinkedIn, you support national and organizational teams to plan and action interventions for better care and health outcomes. You specialize in health systems and rapid introduction and adoption of innovation and health workforce development. As a result of this, Dr. Rupa Chilvers is currently, since March 2024, Deputy Director for Life Science and Innovation at the Welsh Government. For the benefit of the audience, let me add that the Welsh government, as well as my government, the Catalan government, they are cooperating in the brand new Disruptive and Emerging Technology Alliance that Raquel referred to some minutes ago, which is a global network of regions exchanging know-how and best practices on how to take the most of technology by respecting human rights, democratic values, and cultural diversity. And as explained by Raquel, this network held the first ministerial meeting last week in Barcelona, where a representative of the Welsh government did participate, Her Excellency Rebecca Evans, Cabinet Secretary for Economy, Energy and Planning. And one of the main outcomes of that meeting was the approval of the SET manifesto on advanced trustworthy AI, which can be consulted and eventually endorsed by all those interested on DITA's webpage, which is ditalliance.com. So Dr. Rupa Chilvers, thank you for being here with us, coming from Cardiff. We are eager to know how the Welsh government is coping with the AI revolution when it comes to offer services, especially healthcare. Thank you so much.
Thank you very much for the opportunity, and thank you for the LinkedIn-based introduction. Today, I just wanted... Is there a clicker there? I just wanted to talk to you a little bit about maybe the practical side of what happens with ethical AI. So I know you've heard the policy side, so from a Welsh Government point of view, I will cover a little bit in terms of how we have dilemmas that we have to work through when it comes to ethical implementation of AI. My perspective does come from working with clinicians and managers in the system, but also as a researcher who's seen knowledge come by, never get implemented, or take 17 years or 20 years or 25 years, and sometimes 2 years. So a lot of the experience also comes from talking to researchers and industry who work in this area and want to do something good. So the given is we all want to do something good. What we're trying to do here is see how fast we can do it, but responsibly and ethically. And AI has that dilemma in the way that we think about it in policy, but also in practice. But before I start, I wanted to say something about Wales. So it's important to note that Wales, in the way we work across the 4 countries, is very much embedded in how UK looks at the ethics regulation and the legislation around AI, and in terms of practice, professional practice is also a UK government remit. So when you look at Wales, you have to think about what is devolved to us to do differently, and what do we do because we're part of the UK. But in terms of a nation, we have 10 organisations that work in healthcare, some of which are national, and we have 22 local authorities, and around 90,000 people who work in healthcare and around 85,000 people who work in social care. It's important for me to emphasize that because we talk about healthcare, but some of what we land through AI and through these decisions are also in social care, and they will default into social care the more we talk about community and what happens in the home. unless we're careful, we will end up creating differences in the way we look after people because they're looked after by social care, for example, in a care home, or because we're independently living in our own homes. So it's really important, as we talk about ethics, to think about health and social care. In Wales, we have a few strategies that inform our work. One of the ones we usually refer to is a Healthier Wales. And the idea with a Healthier Wales is to give us some areas of priorities that we can focus on. So that's where we start to do something slightly differently to what the UK might talk about in terms of priorities. We also have Health and Care Research Wales, which is a one-stop arrival point in Wales to think about research and how you might actually engage in research. And we work with UK OLS, Office of Life Sciences, on the Life Sciences vision. We have a social care innovation strategy that is trying to push forward innovation. As part of that, we're trying to reach the health and social care staff of the 170,000 or so to think about how they might come into play for innovation and AI. It's so important that we think about that now. It's really important for me to emphasize that we're one of the few nations in the world who have the Wellbeing of Future Generations Act, which lets us think about the child not yet born. It lets us make decisions because of the child not yet born, because of our children, our babies and our children, thinking about what's coming in the future and the impact that might have in terms of the decisions we take today. So, integrating AI in healthcare. What I wanted to bring to you is this dilemma. So, it is essential, we do want to do it, but it's challenging. Some are easy wins, and some of that is in the back office, part of what we do. Some of that is in imaging, because imaging exists as a digital product. If it does exist as a digital product, it exists and we can use it. But what we really also worry about is if we don't keep up, what does it mean for our recruitment and retention? What does it mean for someone who wants to come and work with us if we don't have the right technologies in place? So this is not just about the patient for us or the population. This is also about the people who will work in today's system and also tomorrow's system. And in Wales, we do have to sometimes work much harder to attract some of our workforce in and keep them there. So there's a perspective I wanted to talk to you about, and then I'm going to talk through an example. So the bit that I have hit over many years, not just for AI, but the issue lies in AI in the way I'm going to talk about it, is if it's slightly not equitable, and I'll work through what slightly means, is that okay? So we're mostly there, it's working, but it's not going to work for everyone. So what do we do? And as a policymaker, I would take a different stance to a practitioner or clinician or someone looking after a population. And this is the dilemma I just want to bring to you. And I'll bring it to you for discussion. I have no real answers, but I'm bringing it just to spark conversation. It's an example that's played out in the UK, funded by government in some pilot projects taking place somewhere in the UK. And these are the conversations that spark the next part. If I don't keep up with somebody else, what does that mean for me? Maybe I don't want to keep up with somebody else because I do see it as unethical. I do think it's going to bring a population over to one side of care, which feels like another tier, a lower level tier of care. So what am I talking about? The example I want to bring to you is in oncology, and it's in cancer care. So around 165,000 people in Wales are referred for suspected cancer. There's a high likelihood, 90% of time, that they will not have cancer. These are the dilemmas we're playing with in the system. So you have a potential solution. The solution at the moment when you have a skin lesion is to have someone look at it. So that's your visual human inspection. AI comes along and says, actually, if you take a picture of that, I'll give you a tool and it will go faster. Don't need to have a human look at it anymore. We go, okay, so we don't need the human to look at it, but let's just have a look anyway. And the ones that you then make a decision to look at is the one where AI is going to say, don't put them on the suspected cancer pathway. And then you put a human to go, the ones that didn't go on the suspected cancer pathway can have a human. And that becomes really expensive for the system. AI will cost, the person will cost. And for the conversation that was had just before, usually what clinicians say is, I can't actually override the AI. What they don't do, what they don't feel safe to do, is to override an AI decision when it says, put them on the suspected cancer care pathway. They do feel able to override AI when it says, don't put them on there and send them home. This is the dilemma. And the very novelty part of it that these companies want to do is to go autonomous. So they have data to say when the human override took place and the person was sent on the suspected cancer care pathway, the human was wrong. They didn't need to be there. So it's a dilemma of cost, but the real dilemma that we talk about is the eligibility criteria. So worry less about the technology, assume it's sorted. Now we go into practice and we say, let's make this happen, guys, because it's really great, isn't it? So we start to hit eligibility criteria. So the eligibility criteria for image being taken is that you shouldn't have a tattoo. So I'm out if I have a skin lesion there. Shouldn't have hair in the area that is the photograph's been taken, and therefore you can join that pathway. And then say you take it outside of the hospital, or the general practitioner is looking at it, and give it to a healthcare professional, and you set up a clinic, and then you say, don't take too many images, because we can't have 5, 10 images of the same person's issues. Let's have 3, because we don't have time in clinic. So these are the areas of implementation that starts to hit the population. So now you're moving from a current pathway that's fully human, all treated the same, whatever wrongs the human has, all treated the same. Then you add a current pathway with an add-on. That feels okay, but you started excluding some people. Then you add a brand new digital pathway, and then you add some more layers. So what are you doing here? You're actually creating a 2-tier system. So you've created a 2-tier system where within 5 minutes, or if you put a human in the loop because I was told I didn't have suspected cancer, maybe 48 hours for someone to turn it around, over to a 5-day system for the person who did not meet the eligibility criteria. What's happening in that time? We're also then saying, maybe we can use the AI to actually risk stratify. So we can work out who actually needs to be seen faster. So here's a group that will never make that pot. What are we doing with that? And these are the dilemmas that are stopping AI being implemented in our system today. Because someone is taking a risk with that decision. But mostly, we have a law that says we treat them all the same. So what do? Do we create another pathway for them where a professional is going to do a 5-minute diagnosis? I don't know. So that's the dilemma that's playing out at the moment. So in Wales, what we're talking about is how do we create enablers in this space? So one of the enablers is that we have the AI Commission for Health and Social Care that works across health and social care system and led by Welsh Government in the way it was set up. What we're trying to do there is help our colleagues in health and social care feel safe about the decisions they're taking, bring in some of these international, UK, EU, and all that knowledge into spaces that helps them create some environments, safe environments where they can have these discussions. But it's really hard to overcome that type of example when we start to create 2-tier pathways, because AI can do most of it, but not all of it. But mostly what we're saying today is that actually how you design the service, and remember, it's not always the clinician designing the service. There are managers designing services. The example I gave you, majority of the work in implementing those clinics were not done by clinicians. The responsibility and accountability sat with general practice in those examples. The majority of the work were done by project managers, commissioners, and operational managers. So that's service design. So don't forget them when you design your projects. So we go from service design that we used to think about, which is where are we going to place the service differently? Who are the roles? We spent about 15 years talking about new roles in health and care. They're just about coming to fruition. Who are the roles who are going to take part in this? And are we doing something good to the system? Now, what we're saying to our colleagues is actually think about service design differently. So where is digital? It's at the forefront of the conversations that you should have. So what is it about the discussions you're having about your clinic that can go to automation straight away, that can go to AI straight away? Or if you don't have that, which tasks can you bring in? And then we're looking at the digital infrastructure. And it's not easy. We're not, these are hundreds of millions of pounds infrastructure that we sometimes have to deal with. So that's also where we're going. But with all of this, how do we signal? So we call it social partnership in the way we talk about it in Wales in AI Commission. We talk about it as social partnerships. How do we signal with the employees, with the employers, and with the people involved in AI as to what's happening in this system? How do we take that discussion forward? So we have to do all of that in parallel. Most importantly, what we have to do for ethics today is to think about what is it we can do in the service that helps fill the gaps. What is it in terms of how we design the service can we do to give you data back, give others data back in terms of what can fill the gaps that you're talking about. So if it is that you have a tier system today, how do we make sure that you actually start to fill the gaps and stop creating that tier in the future? And for that to work, what we're urging people to do is start early. So what we used to do in pharmaceutical drug discovery work does not work in AI. You don't come into the game later on and say, how does this work for the service? You have to come into the game early on, engage with the people. Usually TRL level 7 and 8 and 9 is where you talk about it. Do it earlier. Observe how it sits in the system. Systems will be different, but on the whole, you can pick up 2 or 3 scenarios quite fast. Pick it up and run with it earlier in the way that you develop the work. So really, it's points for reflection. Do we want tiered systems? Do we want tiered systems because AI can do most of what we want when we look after people? And is that ethical? What can we do earlier to actually stop those type of examples playing out? Or if they can't be stopped, what are we doing to help the decision maker who's worrying about it, who has to sign off on ethics and safety, to actually say, it's okay if you do this for 6 months, we have other developments in play that will help the people you are leaving out as it plays out today. What's that conversation? It can't come from the service. It has to come from the people working in AI. So most importantly, research, innovation, knowledge transition cannot be a side effort in AI today. For the next 10 years or so, we have to play this out together. So investment has to flow through with research, innovation, and knowledge transition in mind. Even when we think it's going to be expensive, we have to do it to make this an ethical space to work in. Thank you very much.
Thank you so much, Dr. Chilvers. So we've seen a shift from regulation, from parliament to government. We are getting closer to patient. And now it's time for your questions. Please, we have some minutes. Over there, there is a gentleman in gray.
Thank you. Really enjoyed hearing you talk about the practical problems. Curious to hear, in your experience, the dilemma between mistakes in AI and false positives, false negatives, whatever. Humans make mistakes. We tolerate that in the healthcare system today when a clinician makes a mistake. But I feel like sometimes we are expecting perfection from technology. Are we practical in saying, well, if the error rate is similar or better than the human clinician, we can still tolerate new technology? Or how does that play out in practice?
So I think it plays out differently for different clinicians. Some of them are willing to take a bigger risk than others. Where I've heard it, where it's been hard to process, is the type of AI or let's say algorithms running into notes, text-based notes. And they'll say, if we do that, we can identify people who may have, for example, dementia, identified in their notes in some way. And we can do that around 10 million notes, because we can, right? And they'll say, well, you don't do that right now, so it's unethical that you're not doing it right now. And then they'll say, actually, the error rate, we don't know, because we haven't compared that with the human, and that this does play out in terms of how industry does talk to us. But it's unethical that you're not doing that, and then the output of that is that you will surface up some patients to be seen faster because there's something in their notes that's saying you potentially have dementia, or you had a diagnosis for dementia and it's not being picked up anywhere else. And the area that the risk isn't that part, it's the part where we know, for example, that potentially if you're working in a more deprived area, you're writing less notes because you have less time. So the question that I pose back to industry members like that is, what happens in that scenario, because we've just left them out? And the answer they don't give, which I'd love to hear back from them, is actually we do some quality checks along the way that helps us. We do some steps before this wonderful solution that helps us work this through. And they don't think that way because they've got a product. And that's why I say, if you think about this as a technology, we will all fail. If you think about this as a service where we want to make something happen safely, responsibly, and ethically, we will find solutions. So I think the key is to help people build trust, whichever way it works. Our clinicians are taking a lot of flack right now, and they're taking a lot of responsibility about technologies they don't fully understand, and we don't fully understand. So we have to help them go back a step and work out what do you need to be feeling safer, but to confidently move forward with the decision. But yes, we do hold technology at a higher bar than humans. But remember that the humans part of this is highly regulated. So if the human goes wrong in a systematic way, they will do it for a few patients, but they will come up to the GMC. They will come up to the NMC in our countries. But we don't know what will happen with the tech. And that is why sometimes the bar is correctly held higher. That's my view on it.
More questions? Comments?
Just a follow-up on what she said. And I think, Raymond here, I think you explained it very well from a practical perspective. And I have heard most of the talks. One of the things that I would have loved to have heard more that you have been doing or integrated into what you are doing is actually those different processes that you have you included the technology providers? So that actually, people tend to think that AI is already ready solution. It actually is not. AI is still way, way behind to solve all of the human problems that we are talking about today. But one thing is for sure, it's a great technology that can learn from what you are doing to improve it much better. So to do that, doctors are not AI expert. You need to go to the technologies, the industries, and work in partnership with them to build a CI/CD model. For example, your inclusion use case, what I just saw there, I'm from technology background. You need just to have a framework, a CI/CD framework that can help you improve it continuously. The goal is not to get to perfection because it doesn't exist, but the goal is to make small improvement over time to get to a place where we are comfortable. And I would love to see more involvement from the industries, even at the regulatory level and also at the practitioner level. I think that would be more helpful to reduce the barriers.
Yeah, no, very good point. So in Wales, we have a few entry points, if I put it that way. And the most recent one is what we call the Welsh SBRI. So that it's a challenge fund, and the challenge fund, we actually partnered with Northern Ireland in this case. And what it's there to do is support industry members working with health and care. So there's a project that's about to kickstart. I think 3 out of 4 that were selected were in AI. And so they will have hands-on support and clinicians and healthcare practitioners alongside when they're trying to work through how does this actually work. But I would say that I've worked in many countries, and in Wales, we have some very enthusiastic and knowledgeable clinicians and practitioners ready to go on this. And I think they are very willing to work with industry as long as they are able to have the time and the equal investment when it comes into this space. So I think it's really important as government, we're trying to make that happen, but as developers and researchers, that you write that in. Because there's no point thinking that this will happen because someone was enthusiastic and they could give their spare time and they'll work till 9 p.m. to make that happen after a shift. It's not like that for this particular technology. It cannot be for us to go at the speed that we want to. So when you're developing, please think of the clinical setting, please think of the team, and please think of the costs associated with that, and make that happen as well. But in Wales, we definitely, as government, are taking that very seriously, and we have various avenues in. So please do talk to us if you are interested.
Over there, please.
Hi, Carl from Synoptics. I'm quite interested on how informed consent and kind of non-coerced consent fits in with kind of these AI integrated service pathways, because I think you fall into quite a natural ethical dilemma when if you're saying, well, you can be seen by an AI system now, or you can wait 3 weeks for a clinician to decide if you've got cancer or not. Is that really kind of informed consent?
It's a good point. So in the example I gave you, the scenario that was presented was you can go to a clinic outside of your general practice and take an appointment, which may or may not be sooner than seeing your general practitioner, and have an image taken. That's the decision they were asked to make. And then there was a lot of post-implementation experience-based data collection that showed that people were willing to take that route and not see the GP when they actually phoned up saying, I think I've got something suspicious here. I don't think we're yet at the stage where we are saying to anybody, would you do this with AI and not with a human? I think what we are seeing right now is actually the AI, like Brainomics, is embedded in the pathway, and you and I will never know unless I ask specifically that Brainomics was embedded in the pathway. So the question is, should you know? And the current answer that we have is, well, you wouldn't have known what else is embedded in that pathway. You wouldn't have known how many other professionals needed to be part of that discussion. It's a service prerogative, if I use that word, to know that information. But we are doing something different in that space. So there's the algorithmic transparency recording standards that have come into play in the UK and in Welsh government. And what we have in the AI Commission, through the work of colleagues like Gareth, who's sitting in the audience there, is actually said to health and care, we will hold you to account through these recording standards, which will get published out in public. And what you will be able to do there is start to follow the technologies that are running, that are within that criteria in terms of what you record. You'll be able to follow the technologies that are running in health and social care in the future. And that's what we are doing to open up some of that conversation. Whether we're in the space where we're going to have consent based on AI versus human, I'm not sure how far away we are from that, but I don't think it's anytime soon.
It's currently implemented in NHS systems and pathways.
It's implemented in, yeah, but the choice of following it or not following it, is that implemented in?
There's an example that I'm thinking of where you have an AI-based
And we don't have that in Wales yet. So that's why I say we are taking careful steps in that space. I think this is the ethics dilemma, isn't it? And how well will you be informed? How do you have that conversation? Those are the questions we are asking actively. And sometimes that comes back to what I said earlier. If someone else is doing it, why aren't we doing it? We get asked that a lot. And that is one of the reasons we might not be doing it. And that is a fair answer back, I think, in the world we live in.
We have time for one last question. This gentleman over here, first row.
Yeah, hiya. Do you think the current systems in the NHS, both in Wales and the general UK, are really quite ready for everything right now? For example, when you're looking at AI adoption, you've got trusts versus ICBs, you've got DPIAs, all that, and you've got a really poor education level even in doctors right now. For example, there was an AI that was activated in part of London, and some of the results went back to some of the doctors on the weekend. They panicked and they then stressed part of the environment. So do you think we should get our house in order first from a structural point of view before going to AI? But will that result in a massive slow tail and be like 5 years before we do anything?
I think it's horses for courses. So some parts of AI are going to happen faster, aren't they? Imaging, for example, through the technologies that we already have in our systems may be able to move faster. But do I think we should wait and do nothing? No. We're never going to wait and do nothing. We might be doing things in the background that helps us take things forward that may increase time, but none of the conversations, if I speak from what I've heard through the AI Commission and through our work, none of our conversations is we entirely stop and wait and watch. All our conversations are what else do we do now that will help that come to fruition? So the digital infrastructure that we need today is being argued. Saying to our colleagues today that we need it because AI is going to be in play in 2 to 3 years, it's a really hard argument to make, but we keep making it. In terms of workforce, we are taking that seriously. So in terms of skills development, that is an area we're looking at very actively. What we can do en masse is really hard, but in terms of digital literacy and how AI will play out in the coming future is being talked about, but maybe more in the back office, more safely at the moment. So I guess the short answer is we're not stopping. The long answer is, the other part, the answer is some areas will take us longer because it is just more complex and unsafe to proceed. And that's really the safety bar that we might use more often than not.
Thank you so much, Rupa. You can stay here with us.
Thanks very much, Albert.